Good evening, everyone. My name is TRUS Bjerklund Johansen. I am emeritus at University of Oslo, Norway, and the University of Aarhus in Denmark. Welcome to this webinar on prostate biopsy. At lunchtime today, we had 451 registrations. I am one of the founding members of the ESIU and Guidelines Panel on Urogenital Infections. I have no conflicts related to this webinar. I would like to thank Safer Tandogdu for developing the program for us and for asking his old mentor to chair the session. To compensate for my age, we have a very young and energetic faculty dedicated to research in the field of UTI. The first speaker is Laila Schneiderwin. She is a senior consultant at the Department of Urology at the University Hospital in Bern, and she is specialized in urological infections as well as kidney and kidney transplant surgery. She has also research interest in infectious diseases, immunology of the urothelium, and bladder cancer. Her title is Worldwide Antimicrobial Resistance Development and Strategies of Antimicrobial Stewardship in Urology. So please, Laila.
Thank you, Truls, for the very kind introduction. I have no conflicts of interest to report. Yeah, let's start. I'm only the teaser for this webinar, and I'm only supposed to show you how important this topic of trans-perineal or trans-rectal biopsy is, because I will talk about the antimicrobial resistant development in a global perspective, in the European perspective, and will show you strategies for antimicrobial stewardship in urology and how we can overcome this development. And as you all know, prostate cancer is the most common male cancer, and prostate biopsies are the key step in diagnosing this kind of cancer. And so this is one of the most performed procedure in urology. And as you all know, it can either be performed trans-perineal or trans-rectal. Both tests have the same diagnostic power, but it is still controversially discussed what is the best in terms of infectious complications. And this is what I will show you. Due to the rising antibiotic resistant rates worldwide, it is very, very important to tackle the further resistant development. And therefore, I will underline the importance of antimicrobial stewardship in our subdiscipline. And I hopefully can convince you that it is important to think about urological infections and this development. And then my co-speakers or co-chairs will show you the data for a special procedure. And so I come to my agenda. It's pretty short. I will talk about antimicrobial resistance development worldwide and in Europe. And I will show you 3 new studies from this year, which are, in my mind at least, are very important for this topic and for our subdiscipline. And then I will show you what is antimicrobial stewardship and what we can do in urology. So I nearly always show that slides when I talk about UTI and urinary tract infections and my research topic, or at least I show the left side of the screen you see. And this is from the initial O'Neill report. It was published in 2013 and it was sponsored by the World Health Organization. And they did a systematic review and a meta-analysis. So they looked up until 2011 what are the data about antimicrobial resistance worldwide, and did a meta-analysis, and then they calculated a mathematical model what will happen in 2050 when we don't overcome this development and improve our doing or our things about urological infections and other infections. So they calculated that in 2050, the risk dying from the consequences of antimicrobial resistance will be higher than dying from cancer. So you can say, okay, it was 2013, that's long ago, something happened, but not. This report has been updated several times, and we are still nearly, or have still nearly the same picture. And, you know, it's only 26 years, and then we will know. And I always say in talks that, okay, it's fine for us who do research in urological infections, because then we will be the big players in comparison to the uro-oncologists, and we will get the research money and so on. But that shouldn't happen. But there's another report of the World Health Organization, and you see it on the right side of the screen. And it was published last year. And it's about the resistant weights and antimicrobial biological resistance in Europe in the World Health Organization European region 2019. And they calculated what deaths and outcomes are associated with antimicrobial resistance. And here you see the 6 most frequent pathogens associated or directly attributed to death due to AMR. And as you see here, E. coli is the most frequent killer. And it's not multi-resistant E. coli. It can also be only penicillin-resistant E. coli. So we face that quite a lot in urology. And you also know Klebsiella pneumoniae, Actinobacter baumannii, and Pseudomonas aeruginosa. So we know that. And we face that every time we treat it, and we need to overcome E. coli and prophylaxis, like for trans-perineal or trans-rectal biopsy. It's really important for us. So this paper kind of shocked me, because the data are so bad even in Europe. So that's the bad news. But there's also a very positive, or at least perspective in this, because when we urologists treat UTI, which are the most frequent bacterial infections in human beings, we can also change this. When we do good, and we do good UTI treatment or prophylaxis in our subdiscipline, we can change this development or optimize it. So that's why we do the seminar here. So I will show you now 3 studies from this year, which are really important. One is this one. It's about ceftazidime avibactam. It's a pretty new combination antibiotics, and it's from the TRUS program, the surveillance program for antimicrobial testing, leadership, and surveillance. And it's about Enterobacter species, which are really important in prostate biopsy. And the worst part about this is that you see the resistant weights of meropenem or carbapenem, which is the standard carbapenem, and the resistant weights of ceftazidime avibactam. Please mention that it's not scaled the same way I would have mentioned that as a reviewer, but what you see that even a kind of new antibiotic combination has nearly or not different resistant weights, at least in Europe, than a carbapenem. And this is pretty serious. We have a new antibiotic combination, and there's not much in the pipeline, and you already have resistance. And then you see also especially in Asia and in Latin America, the carbapenem resistance and also the ceftazidime avibactam resistance went quite high. So it is also a problem of new antibiotics, and they both are antibiotics you should keep in mind that they are on reserve, and you should not use them in prophylaxis or at first line. So do everybody know about this? Also a new and very good study. It was done in 20 Italian intensive care units with nurses and physicians. And they did a cross-sectional survey about the knowledge about this antibiotic resistance, because knowledge is really important to overcome this. And in their 26-item questionnaire, they had 7 key knowledge questions. And I want to raise your attention to these both knowledge questions. It's the question about antibiotic-resistant bacteria can spread from person to person. This is certainly true. Okay, they know, okay, not everybody knows it, but the kind of still shocking thing, even when it's over 80%, is that healthy people can carry out antibiotic-resistant bacteria. This is true. And I want to raise the attention to that question because you always have to keep in mind that when you do wrong about antibiotic treatment or prophylaxis, or you don't do a good job, you have to keep very, very closely in mind that you not will only cause collateral damage to the individual person, you will also cause collateral damage in the whole population. It's a global problem and also a local problem in your hospital, because resistant plasmids can spread from person to person. And there are some unpublished data from the German microbiome project. We know from that even healthy people not treated with antibiotics yet and no comorbidities have up to 6 resistance plasmids in their fecal flora. So we have to keep that good in mind, that collateral damage in antibiotic treatment is also in the whole population. So what can we do about it? What are changes? And there's a research working group doing a rapid review on what are the good campaigns to improve antimicrobial resistance and behaviors, what is effective. They did a really good comprehensive rapid review, even if it's not only a rapid review in terms of evidence synthesis. And they found out that they included a lot of studies, but I want to raise attention to the effective campaigns. What you should do and is really effective to change minds. So you have to, firstly, you have to use mass media, so reach a lot of people as we're doing here. Then you have to combine the education and healthcare professionals and also the public health, because the patients also should know about the problem and that you don't have to use always antibiotics, because they come to your practice, for example, for uncomplicated cystitis, and they want to be treated with antibiotics, and you can say, okay, with mild symptoms, you can also use painkillers. So what they have to, the public has also to understand this problem. And you have to be focused. Don't say, okay, it's a global problem and it's a problem with antibiotics, but you have to be really precise on a special procedure to keep this. For example, for prostate biopsy, to get the message done, because antibiotics, you need to use it in sepsis. You have to be focused when do what on the special infection or the special prophylactic procedure. Okay, that's it. So what can we do? It's antimicrobial stewardships. What are the aims? I know it's a really, really tough slide, but I will explain a little bit in detail later. So the aim of this procedure is to raise the quality of anti-infective prescribing in terms of the substance selection, the dosage of the subjects, application and duration of the use, in order to achieve the best clinical treatment results while minimizing toxicity for the patients, the resistant development for the patient, the development from resistance in the population, and also the cost. Because when you do a good job here, it's formally known that you can also reduce costs. And what are the strategies to do so? The creation of and updating of local therapy guidelines and pathways, and preparation of an anti-infective house list. And this is not an easy job, because you have to use national and local guidelines, local and national resistance rates, and pathogen situation and resistance situation. And you have to always train the people, train all your staff, and give information and then analyze their doing to have a quality assurance in your hospital or in your praxis. So I make it a little bit easier. Antimicrobial stewardship is that you use the right drug for the right situation. Yeah, and this is not an easy way always to choose, because it has to be the right infection where it comes then local guidelines, national guidelines, and consideration. Do I have all drugs in my country? And what is the patient? It's about dosing, also in terms of kidney or liver functioning. You have to keep in mind, where should it come? The duration of treatment, it shouldn't be over treatment, and you have to keep in mind that you can, when you have a resistogram and you know the pathogen, that you de-escalate. These are the most important things about antimicrobial stewardship. And here also new published consensus guidelines, and they also did, like in the rapid review, said be really precise on what you do on a special infections. They get their recommendations for UTI, and what I want to raise attention for is that urologists most do bad about is to treat asymptomatic bacteriuria, and it shouldn't be treated only in a very, very selected patient group. And then there we can save a lot of antibiotics. And it's also about prophylaxis. Not everybody needs an antibiotic prophylaxis. And we will show you the data so on for a special procedure, like I said, from the rapid review. And I'm open for questions in the chat. And thank you for your attention.
Thank you, Laila, for setting the scene for us. I think we have a couple of minutes left of your time. So you mentioned de-escalation as a measure to improve antimicrobial stewardship. Are you aware of any research initiatives related to de-escalation of antibiotic prophylaxis?
Yes, I am, like we do in the ESU, where you are the founder of. We try to make a big project about de-escalation and prophylaxis in all urological procedures, but we wanted to start, and we are nearly set for the radical prostatectomy, because it's one of the most performed surgeries in our subdiscipline of urology. And I think it is really important to do so, because there's not much evidence for antibiotic prophylaxis in that major surgery. And hopefully we'll get started soon, because it's really important. And further research is also necessary for the other procedures, but because we have not so much evidence in a lot of urological surgery, we don't know a lot from prophylaxis from abdominal surgery.
Yeah. There is a big population of men on watchful waiting who undergo repeat trans-rectal biopsies with broad-spectrum prophylaxis, especially in the US. Do you think this practice puts these men at greater risk of developing multi-resistant bacteria in their own microbiome? It might be a leading question, but I would like to hear your opinion.
Yes, there's no data about that, but or not valid data, let's say it so. But in my opinion, yes, it is so. When you treat a lot with broad spectrum antibiotics, you will get resistance. There, I mentioned the German microbiome project. Unfortunately, the data are not published yet, but I said even healthy people not treated with antibiotics, they also come from food, I know, and stuff, but they have up to 6 resistant plasmids in their fecal flora. So this is an argument for that. And we know from a very good study from kidney transplantation, where they asked, should I treat asymptomatic bacteria after 2 months after transplantation? It was a good double-blind randomized study, and we know that it's not necessary to treat it, but they know that if you treat it again and again, you don't get the asymptomatic bacteria away, but you will get resistant plasmids in your fecal flora, and the bacteria of the asymptomatic bacteria get more and more resistant. That's we know.
Thank you, Laila. Thank you. Our next speaker is Fabian Stangl, who is a senior fellow for robotic surgery. He's also based in Bern, where he's pursuing a PhD focused on urological infections and antimicrobial stewardship. He is a founding member of the newly formed Working Group for Urological Infections of the Young Academic Urologists, and he is also associate member of the ESIU and associate member of the Guidelines Panel for Urological Infections. That means he's doing the hardest jobs. So please, Fabian.
Thank you so much for the kind introduction, Professor Johansen, what I will be talking about in the next few minutes. So thank you and welcome everybody. First, conflicts of interest, there are none in regards to this talk, but of course I'm a member of the ESIU and of the YAU, and I've conducted some of the research I will present today, so this is an inherent conflict of interest. So let me dive into the current evidence. We all know what the guidelines are talking about, but let's dive into the studies and papers the guidelines are referring to. And the latest, or one of the latest meta-analysis included in the guidelines, that's an important topic because I will show a newer meta-analysis later on, is one by Dr. Perdere and Professor Bjerklund. They compared 7 randomized controlled trials. So they gathered all the randomized prospective evidence to get level 1A grading, comparing trans-perineal and trans-rectal biopsy, and included about 1,300 patients, so a robust set. And there was a significantly lower infectious complication rate associated with trans-perineal biopsy. The overall infection rates were quite low, which is important because many of the studies we've been discussing, or we would discuss today, are powered in regard to older data, reporting quite high prevalence of infectious complication and sepsis. So there is a risk of underpowered data. So we see about 22 infectious complications in the trans-perineal group and about 37 in the trans-rectal group. So if we dive into the forest plot, we can see that there is quite a high risk of bias with most of the studies, and there is a significant reduction of overall risk ratio with trans-perineal biopsy. But what's new? That's the question that's everybody into. That's why I'm here today. And let's discuss not something completely new, but something really important. It's the NO-REP trial. The distinguished chairman of today, Professor Johansen, has been heavily involved with. It is an RCT comparing not trans-perineal and trans-rectal biopsy, but trans-perineal biopsy with and without antibiotic prophylaxis, which is a very solid question. And when they developed the study protocol, was something very forward-facing. So how could we reduce the utilization of antibiotics and reduce antibiotic prophylaxis in order to decrease the pressure on overall antimicrobial resistance? And non-surprisingly for us in the ESIU, the study showed in a little restricted patient population that the non-inferiority margin was not exceeded. So there was no benefit of the added prophylaxis. They had 0 cases of sepsis or hospitalization, which shows that trans-perineal biopsy overall is very safe, but it's also very safe without antibiotics. Very well published this year by Professor Hugh in European Urology at the beginning of this year is the PREVENT trial as presented at the EAU. They compared trans-rectal biopsy with targeted prophylaxis, which is very important with a broader spectrum of antibiotics, and trans-perineal without antimicrobial prophylaxis with around 680 participants. No difference in infectious complication was found. Sorry, this was a little too quick. So again, trans-perineal biopsy without prophylaxis is as safe as trans-rectal biopsy with rectal swabs with added prophylaxis. The Pro-BC trial published also this year, not included in the guidelines yet, but published this year by Professor Mian, was a similar designed study with a similar patient cohort and a similar power. And they also compared trans-rectal biopsy with trans-perineal biopsy, most notably in a single center with very experienced interventionists and during COVID, which in my eye adds quite a significant bias to this study, because when patients are allowed to phone in for e.g. fever, which was very, very prevalent during COVID, especially 2021, there is a significant risk of bias associated with this. Again, the ProPC study did not find any difference in infectious complications. Most noticeably published in European Urology Oncology a few weeks ago was a meta-analysis by Dr. Zattoni, and they did a systematic review and meta-analysis of prospective studies that utilized MR and trans-perineal and trans-rectal biopsy. So the primary outcome of this study was more or less the cancer detection, which is similar in trans-perineal and trans-rectal biopsy for most areas of the prostate. They included only 3 randomized controlled trials because the MR limits the available RCTs quite significantly. Again, no difference in infectious complications. So I showed you what everybody has already known before this talk. And now I would like to talk about what's really new in my eyes. And again, disclosure, I will show you data, unpublished data from our study group that is currently under review and undergoing revisions. So our study group, DSIU, and the young academic urologists, a big shout out for this major work to all my colleagues that were involved in especially Professor Vallée from France for the big help with designing the study. So in the systematic review and meta-analysis we performed, we were most and foremost interested in infectious complications. The problem being with infectious complications that fever as a surrogate parameter is not very striking the real topic we are talking about, that's more or less going in the direction of sepsis, significant urinary tract infection needing admission or hospitalization. So we chose hospitalization or admission as a primary surrogate parameter and investigated this topic. We found classic setup of a standard systematic review and meta-analysis. We identified 9 RCTs, concluding about 2,900 biopsies overall. So quite a significant set of patients. Like I said, primary endpoint was hospitalization. And if we look at this specific endpoint, we defined as a surrogate parameter for severe infection. And of course, there is bias associated with this, and we can discuss this in more detail in the Q&A section. We showed that there is a significantly lower readmission odds. The trans-perineal route offers a 72% reduction of hospitalization or rehospitalization, however you put it. No difference was identified in infectious complications with or without prophylaxis, which is very important because the prophylaxis does not seem to add anything to the trans-perineal biopsy when done in a safe manner. Overall, the risk of sepsis was very, very low. Only 4 cases of sepsis occurred in close to 3,000 biopsies. So to dive into the abstract, we screened quite a few publications. And as you can see, again, the odds ratio of 0.28, so 72% reduction, no difference in infectious complications. And it seems that the trans-perineal route, if we compare all the prospective randomized evidence we have, is significantly safer. So the absolute risk of infection, and that's something I would like to stress, and that's something I said in the beginning of my talk, is that trans-rectal biopsy does not seem to be as bad as we always accused it of. But still, most notably, there is a significant difference in those two. When it comes to fever, there is no absolute difference, but this comes down to the study designs of the older randomized controlled trials, because the definition of UTI is not very homogeneous, so very, very heterogeneous. Dr. Pilsen et al. Published a paper in Lancet where they, a few months ago, where they tried to define UTI in a better way and how we should conduct research regarding UTI in the future. So this is something we should keep in mind. The level of bias for all these studies is quite significant. And I wanted to show it to you, like, visually, that especially the older studies from the earlier 2000s to 2015 roundabouts have very high risk of bias due to dropout, due to non-definition of UTI, due to only secondary endpoints. The only studies that looked at infectious complications as a primary endpoint are the newer ones included in our meta-analysis. So if we dive into the forest plot for hospitalization, you see overall favoring or disfavoring of the trans-rectal, and the odds ratio of 0.28 with an overall very low level of heterogeneity, since all the trials we included had a very, very similar study design, obviously all investigating prostate cancer, biopsies, very similar cohorts of patients. If we have a short look at the prophylaxis data, we again see that there is no added value, as it seems of now, for the antimicrobial prophylaxis, but we have to state that only 2 trials did not utilize antibiotics in prophylaxis. The other ones, especially the older ones, had a very, very heterogeneous set of prophylaxis, ranging from only second-generation cephalosporins to triple antibiosis over a course of 5 days with per-oral and intravenous, so parenteral antibiosis reaching carbapenems, which is crazy from nowadays perspective. So to conclude my talk, in my eyes, or in our eyes, we now have a solid level of evidence. In our eyes, it's level 1 evidence. It's not published yet, but it will hopefully shortly be published in a well-respected journal. So prospective evidence is there. There was no difference in compound infections regarding trans-rectal and trans-perineal biopsy, but and overall low level of sepsis. The significance of reduction of hospitalization or admission is not only from a patient perspective, but also from a healthcare perspective. It's associated with morbidity, it's associated with lower quality of life, it's associated with cost. And of course, we can always paint the devil and use the worst case, but this is something we could keep in mind, especially in regards to the sheer number of biopsy. About 1 million in Europe and 1 million in the US, so 2 million biopsies just in the Northern Hemisphere in the industrialized countries, which comes down to a significant number of hospitalizations overall. Again, to conclude, as I said multiple times, and I wanted to stress, as of now, there seems to be no added value of antibiotics prophylaxis. 2 major trials are awaited for publication shortly or for presentation at the next Congress, notably the PREVENT-2 by Dr. Hugh and the TRANSLATE trial out of Great Britain, comparing trans-rectal biopsy in local anesthesia with trans-perineal biopsy in local anesthesia in regards to infectious complications. At the end of my talk, I want to make a very bold statement and open up the floor for our next distinguished speaker, Professor Krantz. In my eyes, clinicians should adopt trans-perineal biopsy without antibiotic prophylaxis, performed either under sedation or local anesthesia as the new gold standard. It is safe, it is reasonable fast. We have an added time of about 3 minutes for trans-perineal biopsy. There is a little more discomfort, but I think that's something we can explain to our patients, we can discuss, and we can reason. And it's also possible to do it in sedation in a quite high number. We do it in our center, 15 biopsies in a row in sedation. That's all possible. That comes down to a good setup and well-trained interventionists. I would like to thank everybody for your attendance and your attention, and for the ESIU for the invitation to this talk. I'm open for question afterwards. Thank you very much.
Thank you, Fabian, for this excellent update on the evidence related to trans-perineal and trans-rectal prostate biopsies. So we will continue now with our last speaker, Jenny Kranz. She is a senior physician in the Department of Urology and Pediatric Urology at the University Hospital in Aachen, Germany. She is co-chair of the EAU Urological Infection Guidelines Panel, due to succeed Gernot Bonkert as chair, and she is also a distinguished member of the steering committee for the German guidelines on uncomplicated and complicated UTI. As a member of ESIU, her research is primarily focused on urological infections. And her title is, now we will learn what the guidelines recommendations are for prostate biopsy. So please, Jenny.
Truls, thank you very much for your kind introduction. Okay, so thank you for having me. I'm happy to give you a brief overview of the guideline recommendations for prostate biopsy. I have no conflict of interest besides the mentioned positions I do have in urological infections. And as you all know, the gold standard for prostate cancer detection remains the histological confirmation via prostate biopsy. And while traditionally performed transrectally, there is growing interest in the trans-perineal approach due to the rising antimicrobial resistance, as you have heard before from Laila Schneiderwind's talk. But however, the trans-rectal approach continues to be used because of several reasons. For example, insufficient expertise in trans-perineal approach, or logistical problems, or cost considerations, reimbursement, or limited equipment. And that's the point where we are right now. If you do a quick PubMed search for prostate biopsy and infection, this yields more than 4,000 results. And the maximum number of published studies are in 2021 with nearly 250 publications. And you can see in this graphical thing that most of those studies have been published in the recent years, as Fabian has told you right before my talk. Focusing on the guidelines, you can see two guidelines which have been updated, the EAU guideline on urological infections, and on the other hand, the latest version of the updated AUA guideline in 2023. And they have diverging recommendations regarding the prostate biopsy. The EAU guideline strongly recommends the trans-perineal approach due to its lower infectious complications after the procedure done. And in contrast to that, the AUA guideline does not provide clear guidance, citing the limited data from randomized controlled trials. And so the AUA concludes that both approaches, the trans-rectal and the trans-perineal one, are safe and appropriate diagnostic procedures. The EAU Urological Infections Guideline Panel has been conducting systematic reviews with meta-analysis since 2015. And Fabian has showed you this meta-analysis before, published in 2021, based on 7 randomized controlled trials with 1,330 patients including, and it revealed a significant lower complication rate for the trans-perineal approach in contrast to the trans-rectal approach. But due to the small sample size and suboptimal quality of the included 7 randomized controlled trials, additional data were incorporated. These were data from a study from England and another systematic review, a population-based study from the UK, to enhance the comprehensiveness and the reliability. And these data led at least to an AAU position paper published in 2021 that recommended the trans-perineal approach as the first choice, in contrast to the second choice, which is the trans-rectal biopsy. And this recommendation has then been adopted and included in the EAU guideline update, making it the new standard in many European countries so far. And I am showing you the latest publication of our updated EAU guidelines, and you are invited to check that to see for further instructions and recommendations, not only on prostate biopsy, but also the recommendations for prostate biopsy are included in this recent publication. And let's see what the update included. As you can see here, 2 sections have been updated, the asymptomatic bacteriuria chapter in adults, but also the peri-procedural antibiotic prophylaxis in prostate biopsy. And diving more deeper into that, you can see here the summary of recommendations with nearly a strength rating of strong. As you can see here, you should perform a prostate biopsy using the trans-perineal approach due to its lower risk of infections complications. And for sure, you should use a surgical disinfection of the perineal skin beforehand. And if you go for a trans-rectal biopsy, you should definitely use the rectal cleansing with povidone iodine in men before the trans-rectal approach. And you should not use fluocinolones for the prostate biopsy in line with the European Commission final decision. And at least with a weak strength rating, it's regarding the antibiotic choice you can make. I will show you this in the next slide, which summarizes all the information in the recommendation table in a nice way, saying beforehand that it's really necessary and crucial to take into account your local resistance patterns for sure, and the local guidance in the relation to the use of, for example, phosphomycin or fluocinolones. So going through that flow chart, you need to ask yourself, is the prostate biopsy really necessary? If it is, you should ask yourself, is it possible to do it with a trans-perineal approach? And if so, you should do it this way because of the lower infection rates and complications. With the perineal cleansing and with or without antibiotic prophylaxis. I'm going to come back on that point in a few seconds. If you have not the option for trans-perineal approach, you need to use the trans-rectal biopsy, and you should definitely, as I have said before, use the povidone iodine rectal preparation beforehand because it significantly reduces the infections complications, and you should use antibiotic prophylaxis. And then the next question is, are fluocinolones licensed, yes or no? In Germany, they are not licensed anymore, so then you can go for a targeted prophylaxis based on a rectal swab or stool culture. You can use an augmented prophylaxis, 2 or more different antibiotics which you can combine, but you need to have in mind the antimicrobial stewardship strategies. So this is not the way we would wish to have it be done. And the third are alternative antibiotics. Phosphomycin, for example, is not longer licensed in Germany. You can use cephalosporins like ceftriaxone or cefixime on aminoglycoside. And the duration should last at least more than 24 hours. That's also really crucial. So then, having said that, the trans-perineal approach, there is increasing evidence from randomized controlled trials that the antibiotic prophylaxis is not really necessary, but we made a panel decision that we await the results of several ongoing RCTs before making a formal recommendation. That needs to be stressed. And for the next guideline update, there has also been done a new meta-analysis, because in the first half of this year, 3 high-quality studies have been published, HUE, MIAN, and PLUSAR, as Fabian Stangl has shown before. And these data underpin the current guideline recommendation for trans-perineal approach due to less infectious complications afterwards. So coming to the conclusion, there is evidence, and this evidence demonstrates that the trans-perineal approach is superior in terms of infectious complications. And there are some advantages in comparison to the trans-rectal approach. As I said, a minimal risk of infection with or without antibiotic prophylaxis. We need to wait for the coming results of the randomized controlled trials. And the trans-perineal approach has a comparable side effect profile, e.g. for urinary retention rate, and we have similar cancer detection rates. This is also important to stress because not only the urinary tract infections are really important, but also the treatment afterwards for the prostate cancer. So if you like, you can dive into more of this topic. We published a recent thing on trans-perineal is the way to go. It's a focus debate for the trans-perineal approach, and you're invited to read that publication as well. And really thank you for your attention, and I'm open for questions.
Thank you, Jenny, for this was another excellent presentation. We have received several questions in the Q&A box, and there is one question from Givi Kuberitz related to risk factors for infective complications, and I would like to address this question to you, Fabian. I'm asking you, did any of the studies you reviewed stratify patients according to risk factors for infective complications?
To be perfectly honest, there is no robust data discussing any significant association with risk factors. But we, on the one hand, we can extrapolate from other urologic diseases, and there seems to be certain patient cohorts at a higher risk for infection after prostate biopsy. Especially some of the studies excluded any previous urinary tract infection, any chronic prostatitis. So this was an exclusion criteria in some of the studies, which is also gives us a skewed view, more or less. In my eyes, patients or patients undergoing biopsy with risk factors we have to be conscious and cautious about are immunocompromised patients, like patients with kidney transplants, as we more or less encounter on a daily basis or on a regular basis, patients with uncontrolled diabetes. There also seems to be a minor association with post-procedural infections with SGLT2 inhibitors. They do not increase overall risk of UTI, but seems to be associated with increased risk after injuries or intervention. So to conclude, no, there is no proper evidence I could cite, but I think we have to just more or less do what we know and protect these vulnerable patients at risk.
There is a specific question here related to asymptomatic bacteriuria. Do you recommend screening of all patients to rule out asymptomatic bacteriuria before prostate biopsy for whatever route you might want to use?
A few years ago, when I performed trans-rectal biopsies on a regular basis, I always screened, and I performed rectal swabs for targeted prophylaxis in order to reduce risk of peri-procedural infection or post-procedural. In trans-perineal biopsy, to be perfectly honest, as of now, I do not screen for asymptomatic bacteria. I only ask for ongoing UTI symptoms immediately before the biopsy. And if there are none, I do not perform any further screening.
Is there any evidence that technical aspects influences the rate of infectious complications after trans-perineal biopsy? I'm thinking of poorly trained urologists doing trans-perineal, which means long-lasting procedures. I'm thinking of number of biopsies, single pore versus multiple needles, etc. Is there any evidence related to the importance of that?
Again, you're addressing a very important issue, but we do not have robust evidence. There for sure is correlation with the technique associated with the biopsy, even in trans-perineal biopsy, with cleansing beforehand, with number of cores, with technique. I'm not aware of any study comparing single port or multi-puncture biopsy, but there is a significant learning curve associated with trans-perineal biopsy, but as is in trans-rectal biopsy. So everybody can learn it and everybody can change their way to perform it of now. I invite everybody to our center to come and visit a high volume center in trans-perineal biopsy. It's perfectly feasible on a high caseload. So lack of evidence we could address, but the question is it necessary with the data we have at the moment?
Then I have a question for you, Jenny. In one of your slides, you gave a little vague statement saying that there is increasing evidence that antibiotic prophylaxis may not be necessary in trans-perineal biopsy. So my question is, how many patients do we need? For how many months must they be observed? And how well must they be described in terms of risk factors for us to safely conclude that antibiotic prophylaxis is not needed?
That's a good question. To conclude safely that antibiotic prophylaxis is not necessary in the trans-perineal biopsy, robust data are required. So from my point of view, a large cohort of patients needs to be included, meaning thousands of patients. And for the time being, I think 3 to 6 months of follow-up should work. 12 months would be fine, but I think 3 to 6 months should be the patients should be follow-up. And I think regarding the risk factor question you asked Fabian before, it is absolutely crucial to stratify patients by the key risk factors, such as age, comorbidities, diabetes, immunosuppression, previous antibiotic exposure, traveling to countries with a high antimicrobial resistance rate like India, Pakistan, Sri Lanka, and history of urinary tract infections or post-void residual. And the detailed reporting on these factors is crucial for understanding which patient subgroups may still benefit from a prophylaxis, and ensuring the findings are broadly applicable. So,
yes, thank you. There is a question here. If you decided to give prophylaxis to a patient with significant risk factors, how would you find the right antibiotic? And what would your decision be for Switzerland? Laila, can you answer that?
Yeah, sure. I can answer for that. I think you need to know firstly about the patients, what are the risk factors, and when it's high risk, did he had recurrent urinary tract infections with what kind of bacteria? Does he have now urinary tract infections? What were his problems? What were the antibiotics he was treated before? And you also have to know the local resistance rates of Enterobacterialis, and you shouldn't use antibiotics in prophylaxis which have a resistant rate locally and in your hospital over 20% or better under 10%. You have to also keep in mind other features of the patient, like allergies and so on. So our decision at the moment is intravenous cefuroxime here, but it is because we have a very low resistant rate on cephalosporins in our hospital. But it depends also on the patient.
Yeah, there is a question here from Asisbek Shumarufov. What do you think about fosfomycin prescription prior to prostate biopsy? Would you like to comment on that?
Yeah, it has it's not approved in Germany and in Switzerland for prostate biopsy. So you are not actually allowed to. You are allowed, of course, as a doctor, but it's not recommended in the guidelines, and it's not going to be paid. And what means prior? Is it real prophylaxis, or do we want to treat anything? Because prior, I don't think is that's not prophylaxis. You have to be really really precise in terms of prophylaxis. 5 days prior to prostate biopsy, it means nothing. That would be treatment. Yeah. If he has an UTI sensitive for fosfomycin, then it's reasonable. But well, prophylaxis is not treatment. You have to be really precise, and also infection is not asymptomatic bacteria. Be precise on the things you ask.
I think that is a very good answer. But we must not forget the reason why we are doing prostate biopsies. And I wonder, Jenny, are there any differences between trans-rectal and trans-perineal approach as regards prostate cancer detection in different prostate regions?
Yes. Yeah, so both approaches are generally comparable in detecting cancer, but there are differences with trans-perineal and trans-rectal approach in terms of prostate cancer detection in different regions of the prostate. So with the trans-perineal approach, this provides a better access to the apical and interior regions of the prostate, which are sometimes undersampled with the transrectal approach. So yes, there is an advantage for the trans-perineal regarding the apical and interior zone of the prostate, but generally comparable.
Thank you. We are soon going to close the session, but I have one final question, which is also for you, Jenny. And I would like to come back to where we started. And what is the reason why you as colleagues do not switch to trans-perineal? Haven't they heard about Semmelweis?
Yes, despite the advantage we talked about that trans-perineal approach gives, including the lower rates of infections, some clinicians have not widely adopted it. And I said before, there are several reasons for that. The reimbursement landscape of the different countries may play a role, but also logistical factors may play a significant role. I'm honest, we do transrectal biopsies in our department, but only if we have a patient with a really high PSA and where we're going to take 3 samples just to have the diagnosis, and the other biopsies are performed trans-perineally. And I hope we convinced you to do that as well in your department. Fabian mentioned it does not take that much longer time, 3 minutes. If you are experienced, it's absolutely comparable.
Thank you. Would you like to add anything to this, Fabian?
Yes, I would like to address a set of questions. Dr. Truffaut added point that there is less rehospitalization, but more one-day hospitalization than in office practice. And I want to stress, like, it comes down to technique, and everybody is able to adapt really quickly with whatever system you have at the moment. I have used different systems throughout my career, and all were perfectly feasible, some better, some worse, but perfectly feasible. You do not need any kind of admission. We perform it in an outpatient setting, even under sedation. Patients usually spend about 90 minutes in our office. They undergo prostate biopsy, including local anesthesia. They usually do not complain of any pain. We haven't had a single infection in the last years, and I record them prospectively. So I know our own data. And I again would like to invite everybody, if you are interested and would like on how to do it, there are mentors that offer training sessions. We are perfectly happy to host any of you. There is no reason to stick to the old game, and we urologists are usually perfectly able and happy to adapt and accept new technology, as we accepted many robotic systems and other technical advances in the past decades. So this is one point I wanted to add.
Thank you. And I think this should be the final word from the faculty. The time has come to close this webinar. And I would like to thank the speakers for their great job with preparing and presenting their lectures, everything for free. And I thank all the hundreds of attendees for their participation. And I thank the European School of Urology for perfect organization and technical support. So thank you all for attending this meeting.